PBMs, pharmacy benefit managers, this was a great idea to get somebody to basically help negotiate drug prices, and especially with Medicare Advantage plans, keep drug prices low. The exact opposite is happening. Now, this is a little bit of a wonky topic, but what the PBMs are doing, they're extracting more and more rebates from manufacturers. So what you're seeing is a differential split and a widening split between the list price of the drug and then the real underlying net price of the drug. And that's because these rebates are coming out. Well, what they're doing and what the effect that's having is when a patient, especially a Medicare patient, Medicare Advantage patient, goes into the drugstore and gets their prescription filled, the percentage that they have to pay is off of a higher list price, not off of a lower net price. And so what you have is patients not only paying more, entering the donut hole when you talk about Medicare, where they have to pick up a larger percentage, and then when they come out of the donut hole faster, it's Medicare that's picking it up. So it's having an adverse financial impact on the patient, on Medicare, which means all taxpayers. Now, the interesting thing at the pharmacy side is that in most community pharmacies, it's bad enough that the PBMs charge these mystical DIR fees, direct, indirect remuneration, pay for play, pay to be in my network. But these fees, but they're usually bad enough at a $3 or $5 fee. They can take a generic drug and actually have a drug that they're paying more in fee than they're getting reimbursed for. But what the PBMs have done, which is really smart on their part, they've realized that these expensive specialty medications like cancer drugs in community cancer clinics, and as you know, community cancer clinics either have retail pharmacies that are integrated into the practice based on state law. In some states like New York, they can only be dispensing facilities. But what happens is they're charging a percentage, and it's a percentage of the list price. So those percentages have gone from 3% to 5%, 7%, 9%, we're even seeing 11%. So think about this. The charging that percentage fee to the pharmacy, and as I said, in many cases, a community cancer clinic, it's off of the list price. So the PBMs have a vested financial interest for that list price to be as high as possible and extract more rebates. Now, the interesting thing, the PBMs will say, but we share those rebates with the plan sponsor. In most cases, the plan sponsor is the PBM. They're in the same corporation. So you have this unbelievable phenomena where I call the PBMs the judge and the jury and the executioner. They're even the sheriff. So that's the problem is, and you've seen the PBM industry consolidate into about 3 big players who actually control about 85% of the prescription drug market. So an adverse impact on patients, an adverse impact on Medicare, that means all taxpayers, but a real adverse impact in terms of those practices that have retail pharmacies or dispensing facilities. And one other thing, COA just released a paper looking at not just all the finances, but the impact on patient care. And more, the PBMs are dragging out patients getting their prescriptions. In some cases, they're actually switching medications. They're changing dosages. So they are literally making decisions that would be a decision made by the oncologist in cooperation with the patient, and the PBM getting in the middle. And in most of those cases, it's actually downright illegal. So you're going to see a lot more, not only legislation coming out of Washington, D.C. There are actually 3 bills, 2 in the House and 1 on the Senate, that deal with PBMs. You're going to see some more bills coming out. But I think you're going to see more action of sort of corralling these abuses, not only from a financial perspective, but most importantly, and it always comes back to this, is from the perspective of hurting patients in terms of adverse impacts on patient care.